Good morning, everybody. Welcome from me and Edwin Ho to our Monty Heart Cath Conference again this week. And it's a real pleasure for us to have a good friend from New York, Gilbert Tang. For those of you who don't know Gilbert, he's a cardiac surgeon by training, but he's probably one of the most well-known structural interventionists as well out there. He's done a lot of research in lifetime management, in commissural alignment, and mitral, tricuspid, and a lot of the things that Gilbert have published, I think a lot of people use in their daily practice. So it's real honor, Gilbert, to have you in our Monty Heart Cath Conference. And we thank you for taking the time out of your day to spend an hour with us.
Well, thanks so much, Azim and Edwin, for the kind invitation. Happy New Year, everyone. And it's great to be back, actually, to this excellent conference. You guys have some really outstanding speakers. So congratulations to Azim and Edwin for their leadership. So I'm going to talk today about a pretty hot topic right now, actually. I would say at least for the past couple of years. And actually, Azim was one of the first people who published a paper on this subject in JACC Imaging. So it's really paved the way for now, increasing number of patients that we need to talk to at our valve center and clinic about lifetime management after TAVR. So these are my disclosures. And of course, I'd like to thank some of these trailblazers in terms of working on this field. So just to remind everyone, TAVR has actually surpassed all AVR volume as early as 2018 to 2019. So really, it's now the default therapy for aortic stenosis. And you can see now, this is a little dated in terms of numbers, but certainly 2023 is likely going to be over 100,000 TAVRs being done in the United States. Of course, patients are getting younger as well. I'm sure you see that at your own clinic. You can see the low-risk patients on average around 75 years old. However, the guidelines, at least in the United States, still basically recommend TAVR or SAVR when you're age 65 or older. In Europe, however, is actually 75 or older. Of course, we know that surgical risk category is no longer really relevant in terms of TAVR candidacy. However, that's more for risk stratification in terms of procedural risk and post-op management risk. There are a number of devices now out in the market. In the US, you have the SAPIEN 3 Ultra with Vasilia, the Evolut FX, and Navitor valve from Abbott. However, there are other devices available in Europe or in clinical trials. So SAPIEN X4 is currently in a trial called Alliance, and the Accurate Neo 2 has already completed the US IDE trial and maybe even get approval next year. Now, when we talk about lifetime management or life expectancy, we need to think about the patient's age, right? So, for example, if you're age 65, you probably be expected to live around 20 years. And if you are in 70, oops, sorry, pressed the wrong button. So if you are age 70, you can see that it's around 15 years. If you're close to age 80, it's around 10 years. And once you're an octogenarian, it's really talking about 5 years of survival. So how do we get patients to live to the mid-80s? That's really our goal when we see these patients. This nice EHJ review show that the potential sequencing as the patients are younger in terms of what might be the first intervention versus second intervention, maybe even third intervention. And you can see that if you're in your 40s or 50s, surgery really should be the default option. However, once you are getting a little bit in the 50s, 60s, we're now increasingly seeing patients trying to request TAVR. And of course, once you're in the 60s age, depending on your ability to do re-intervention, surgery might still be a preferred option. And so now, what about the re-intervention rate after surgery or TAVR? So you can see with surgical valve or TAVR staff is around 5% because obviously surgical valve has around much longer. However, with TAVR, you can see now it's still around 0.5%. And in fact, I can tell you, and we can have a discussion later, that we are actually seeing more failed TAVR now for the last 2 years. So you can see that from the first paper in 2020, there's been a lot of publication and interest actually on this subject. And you can see that will just continue to increase. Now, what about the incidence of redo TAVR? This is from the United States Medicare data. You can see it's still relatively low, similar to the TVT registry at around 0.5%. Mortality at 30 days, however, is around 6%, so it's definitely higher than index TAVR, and stroke rate around 1.8%, but low pacemaker rate. And this is Uri Landis, the Redo TAVR registry that some of us are part of. And you can see here the failed TAVR valve, at least in their numbers, were lower at 0.22%. However, the hemodynamics were acceptable, low rate of coronary obstruction and mortality. And of course, this is a highly selected group. There's a recent paper published in Lancet from the TVT registry looking at SAPIEN 3, a balloon expandable valve in failed TAVR in general. And you can see that I'm just going to give you a quick snapshot of the outcomes. You can see this is match data to the claims, Medicare claims, and the 3 years you can see compare native TAVR in TVT registry, Redo TAVR with balloon expandable valve is pretty much the same in terms of outcomes of mortality. If you look at Edwards in Edwards valve or Edwards versus non-Edwards valves, there has not been really a major statistical difference. The reintervention rate, however, Redo TAVR is higher. You can see here, even though it's around 1% at 1 year, is definitely about 5 times as high as native TAVR. So the question is about durability of these Redo TAVR cases. The other thing that was interesting is that the mean gradient actually was higher if you have balloon expandable in a balloon expandable valve versus a balloon expandable versus non-balloon expandable valve, meaning that most of the time in the United States is pretty much the Evolut platform. So if you put a SAPIEN 3 in Evolut, you may actually have a lower gradient than if you have a SAPIEN in SAPIEN. So how do we decide what to do when the TAVR valve fails and when the patient comes to clinic? So you clearly need to do some diagnostic workup. So the first thing obviously will be transthoracic echo, which will determine what the mechanism is. And we often would do a TEE because especially in paravalvular leak, you want to be able to localize it and determine whether the mechanism is amenable to non-TAVR intervention. CT is very helpful, especially if the mechanism is structural valve deterioration or even PVL. And finally, I'll tell you why aortic angiography is actually one of the valuable tools in terms of case planning and determine feasibility. So you can see that here, for example, in structural valve deterioration on the left side, if Redo TAVR feasible, certainly it's a low-risk procedure when that's proceed. If it's not feasible and the patient's a surgical candidate, then TAVR explant is really the only option. If it's paravalvular leak, first of all, can you post-dilate the valve to reduce the leak? If you can, then obviously that's great. If not, then you might consider post-PVL closure. If the other option is if Redo TAVR is feasible, then that's another option as well. Finally, with PPM or prosthesis patient mismatch, if the patient's a surgical candidate, you really have no other option other than TAVR explant. If it's not a candidate, there are instances where you might be able to put a supraannular self-expanding valve to improve the hemodynamics and may result in reduced PPM in these patients. So in terms of workflow, certainly we would do a CT scan to evaluate the geometry of the valve and the aortic root. In terms of Redo TAVR feasibility, you can see these are some of the factors that will be determining whether it's risk of coronary obstruction. Sizing is certainly very complex, unlike TAVing SAF. And finally, even positioning may vary, and that could determine coronary obstruction risk. So because of that, there are a number of patients, vocabularies now that you need to be familiar with when we talk about Redo TAVR. So first of all, is this concept called neoskirt, meaning how the valve can become a tube graft when the second valve is implanted within the first one. And then what we call the functional neoskirt depends on the depth of your first valve implantation. A high implant is going to likely increase the neoskirt height as you see here. The neoskirt plane is really where the top of the leaflet of the first valve basically end up becoming a tube graft. And you need to be mindful of that, and I'll show you some of the nuances involved. Leaflet overhang is basically talking about a second valve implanting within the first valve, and if the first valve leaflets are taller, would they drape over the second valve and cause dysfunction? Now, we know that a number of instances that the first valve might be underexpanded. And so the question is, do we need to expand the first valve to create a more favorable landing zone for the second one, such that the second one does not end up underexpanded? And finally, you can see that for the acroneal valve, you can actually deflect the leaflets outward beyond the frame and can increase coronary obstruction risk. So the reality is that the Redo TAVR feasibility is combination specific. So the first concept is that what is the combination? So I think the easiest way to say this is short in short. You can see like basically like this, tall and tall, tall and short, or short and tall, in which case there can be multiple planes of the new skirt. So for example, here you can see the concept 2 is what are the landmarks on the devices. So for example, with the SAPIEN 3, you see the Commissural tabs. The top of the tab is essentially where the leaflets will be pinned up against, versus here with the evolute valve, you can see that it depends on the node. So we actually calculate the measurements of each node up to 6 where the Commissural sits, as you see here. Now, the third concept is the coronary wrist plane. What that is defined is the bottom of the coronary takeoff. So you can see that here, for example, this orange line represents the bottom of the CRP. And you can see that here, with this particular case on the right side, the CRP is actually above the top of the Commissural tab. So this has some more of a relevance in terms of coronary access after redo TAVR. The fourth concept, this is very important, is called neoskirt plane, and this is where the leaflets will be pinned open. So you can see, for example, here, the SAPIEN 3 is actually not the top of the crown, but actually top of these frame here. That's where the leaflets will be pinned. Okay, so you can see that here, the neoskirt height, however, depends on the valve itself. So you can see the leaflet height varies from valve to valve. And of course, you can see that depending on the depth of implant, if you implant the valve deeper, the actual neoskirt plane will be lower, as you see here. Now, in terms of the combination, as you can see again, if you have a tall and tall combination, it's going to pin all the way up against the top of the first valve. However, tall and short, you'll still be pinned against the top of the first valve with the short valve. With the short and tall combination, though, you can see that here, it depends on where you put the second valve. If you put the second valve lower, you can see that here, the actual pinning of the leaflet of the first valve is only going to be up to the top of the second valve here, the SAPIEN 3. However, you can see as you go up higher, the leaflets will pin higher, and so your coronary obstruction risk may become higher. And you can see also for the accurate neo, you have really 2 levels of target for the outflow. So here's an example in terms of how to analyze this. The concept number 5 is when the coronary wrist plane is below the neoskirt plane, then you may have to assess coronary obstruction risk, because you can imagine you can seal off the aortic root that way. But if you look at the figure on the right side, you can see the coronary wrist plane is above the actual neoskirt plane, because that's the top of the second valve. That's going to be pinning the leaflet of the first valve. So you might be able to get away with not a low risk of coronary obstruction. So what measurements do you do? So this depends on where you're going to pin your leaflet. So for example, on the left side, I know there's a lot of variables here. If you're pinning of the leaflet here, you can see that the blue line, which is the neoskirt plane, is below the STJ. You're not going to need to measure anything related to the STJ, because it's all going to be where the sinuses sit. And you can see that here. And we define it as VTA, and you pick basically the narrowest measurement, because that's where the rate limiting flow to the coronaries will be. If, however, the neoskirt plane is going to be above the sinotubular junction, you can see that here, then really the only measurement you care about is the VT-STJ, because that's going to be usually the narrowest portion of the space that perfuses the coronaries. So you can see that how it works. You can see if you look at an on-force view, how the second valve is a balloon expanding valve. You can see create a virtual circle, and you can see that with the self-expanding valve inside. The balloon expander valve is kind of similar concept, but you now measure the balloon expander valve, the first valve, as the outer margin. So it's a little bit different in terms of how you measure. Now you can see this is the leaflet overhang effect I was referring to earlier. You can see when you implant the valve higher, the second valve, the S3 in the evolute, you can see there's very minimal leaflet overhang, meaning the leaflet from the evolute is unlikely going to drape over the SAPIEN. However, if you look at the video on the right side, these are normal leaflets, obviously, so it's not going to be this bad looking with diseased leaflet, but you can see with the evolute leaflets, you can actually potentially drape over and change the geometric orifice of the outflow of the actual overall valve. Now, when I talked about under-expansion earlier, this is a prime example of a 26S3 nominal inflation. The pre-TAVR CT was 451, so certainly it's quite oversized. And you can see the post-CT clearly is not even close to a 26 millimeter valve. In fact, nowadays, we would have put a 23 SAPIEN 3 at our center because we feel that you get a better expansion, as you might see here, had it in the 23S3. So you need to figure out whether you need to expand this more to create a landing zone for the second valve, as long as you can do so safely. And so you can see this example where rather than going a 26 millimeter balloon, we actually do a 25 because we worry about rupture risk. And then after that, we implant the evolute, and we could gain post-dilate to optimize the frame expansion of the evolute, but also minimize what we call the frame-to-frame leak, because now you have two metal frames against each other, sandwiching the leaflets of the first valve. Now you can see that this is an accurate Neo2 video showing that when you put a SAPIEN 3 inside the accurate Neo2, you can actually expand this leaflet because there's no cage of the frame constraining it. So this is very important consideration, especially like a TAV inside situation. You can obstruct the coronary with the first valve leaflets because they're deflected outwards. Of course, we haven't talked about the possibility of the evolute frame expanding further as well. So you can see that here, when you put a SAPIEN 3 in a No 5 and you oversize it, you can actually expand this more outward beyond the nominal dimension of the evolute. So when you do your CT analysis, keep that in mind, because even if you think that the coronary obstruction risk is low, if you put the SAPIEN 3 here and you expand further, you might end up obstructing the coronary, and that has been reported before. Certainly, there are a lot of variables to measure, and I won't belabor the time here in this presentation. But I think it is valuable to look at the pre-TAVR CT because you want to see whether it's a bicuspid versus tri-leaflet valve. And also you want to see how oversized or undersized the index valve was to the native anatomy, as I mentioned earlier. In terms of the second valve, especially the balloon expander valve, we might need to size the native annulus in addition to the first THV dimensions. And of course, you can actually use the coronary and sinus size as references to determine the index TAVR implant depth. So I've done some YouTube videos explaining how to work these patients up, and I'm actually in the process of modifying this because since even 2 years ago, we now have a lot of advances in our understanding and workflow. And I would say that download these two apps. The Redo TAVR app has not been officially launched, but it should be coming this spring. And that will tell you how to work up these Redo TAVR cases, and you can input all the CT parameters and upload some, and you can actually download it as the final report. With the TAVR Cafe, it can teach you how to access the coronaries after index TAVR. So the workflow, essentially, you can see here, it's a number of steps involved in terms of inputting the data. And so what I would also say is that in addition to CT, fluoroscopic analysis, I think is also extremely important because it's much higher resolution, there are no artifacts, and you can actually directly plan your procedure by looking at where your target outflow is going to be with your second valve to avoid coronary obstruction. And typically, we would do this in an LAO cranial view to take the parallax out. And you can actually use an aortogram to determine the neoskirt plane versus the coronary risk plane. So let me give you an example here. You can see that this is a portico valve. You can see the high implant would be the Commissural post. A low implant would be what we call node number 2 here. This is 1, this is 2. So you can see this particular case where the fluoroscopy shows clearly the portico implant was very low. You can see that here. So you can actually still implant the second valve with the SAPIEN 3 at a higher position rather than the lower position. And so here are 3 examples of SAPIEN 3s of how they look on CT versus how they look on fluoro. So the first case, you can see you might be concerned about coronary obstruction because look at the top of the valve is really against the left main orifice or the coronary risk plane. But you can see that here in angio, it's clearly well below that. So coronary obstruction is not an issue at all. Now look at this second case here. You can see, oh, look at the left main here. You look like you might have enough space to do a Redo TAVR. But look at fluoroscopy. The frame of the S3 is completely buttressed against the sinotubular junction. So you can see that clearly this would not be feasible. And then the third case is a SAPIEN classic valve. You can see that, 4.4 millimeters certainly looks quite generous, but you can see that here an angiography is certainly much closer. So if you plan to expand the sapien valve before you implant the second valve, you might run into coronary obstruction risk because you can see the coronary risk plane is below the neoscript plane. So now why is commissural alignment important when we do TAVR in addition to coronary access? Is that you might be able to modify these leaflets and actually reduce the neoskirt plane to what the inner skirt would be, and you can see that how much the difference it can actually make. And so just to remind people what commissural alignment is, you can see on the left side, it means that the commissures of this transcatheter valve is lined up with the native commissure, so you have a lot more cells to engage the coronaries, and you can even split or remove the leaflets. However, if you are facing the commissural post with the coronary, you really cannot remove the commissural post directly at all, unless it's surgical in nature. So of course, now it's important in TAVR as well, because it's not just about coronary access with total valves, but you can reduce the coronary obstruction with TAVR salve. You can increase the likelihood of redo TAVR as well. As I mentioned before, there might be now some data on durability and halt with commissural misalignment. And finally, of course, you need alignment to be able to do any leaflet modification. So of course, this is an example here where you can do what we call balloon-assisted basilica to try to improve redo TAVR feasibility with the evolute valve as shown here in this example. Of course, this actually only works if you have commissural alignment. And of course, with coronary access with two valves, we now need to figure out not just the commissural alignment of the first valve, but maybe the second valve as well. So for example, here, you can see with the first valve being a short valve, the second valve, you certainly want commissural alignment to get coronary access. But if your first valve is the tall valve, then you better make sure that the first valve has commissural alignment. Now, the reason is that if you look at this paper, if you do two valves, you can't really preferentially align the frames together in a perfect overlay. So you can see now the cages completely overlap and the cells themselves no longer as big as you thought they would be. So coronary access by default will likely be much more difficult. Now, there are tools now that we're developing to look at redo TAVR and how to work these patients up. So we're looking into a potential sizing chart into the dimensions of different types of valves and sizes and what combination that might be possible. And also, of course, Mini's mobile app on the workflow that I mentioned before. So I'm just going to quickly look at the different valve types just to educate the audience what they look like. So the most common one being Sapien 3 or Ultra, you can see where the neoskirt plane would be in terms of how you measure the sizes. It will be outflow, the waste, and the inflow. And there are a lot of different possibilities to put in as a second valve. With evolute, we typically, you can see the neoskirt plane. You need to measure 4, 5, or 6. That's where the outflow of the Sapien 3 would be. And you can see that here with the balloon expandable valve, you actually have to measure at different levels, and you have to average them out. That's probably the most common valve being put as a second valve because of risk of coronary obstruction. Now, what about portico navitor? Same thing. You can see there's a much bigger open cell, so usually there are 3 nodes to speak of in terms of the measurements, and you can see that how you measure the average of these nodes will determine your Sapien 3 size. Acroneo is a little bit interesting. You might have to measure 4 different levels in terms of the commissural tab, the top of the upper crown, the bottom upper crown, and no one. This might not be easy to see, but certainly Sapien 3 is really the only ideal valve in this situation in terms of sizing and implantation. Lotus valve is no longer in use, but you can see that it's also interesting how you might have to measure different aspects of the valve in terms of sizing as well. And most of the time you can see you have to size based on the 4 levels that are prescribed here. Now, these are some of the examples of the different combination. You can see this patient in a 23FX in a 20S3. And you can see you ideally want to implant within the S3 to optimize the hemodynamics when feasible. You can see this patient a very horizontal aorta, a 26S3 Ultra in a 29 Evolute Pro. We, in fact, here protect the left main just to be sure. And this is actually a very good way to see where your outflow should land because the coronary guide is very nicely positioned to actually give you that landmark. And then you can see this third case is a 23S3 inside a 27 navitor valve for paravalvular leak. Now, I want to mention briefly about TAVR explant because a lot of misnomer what this is. It's actually not the same as first-time AVR. And people say, oh, just do a TAVR explant, you'll be fine. Absolutely not true. I can speak from a surgical perspective. Because with TAVR, when you do it the first time, you take out all the leaflets, you have a clean plane to sew into the new valve. Even redo TAVR, you can still have a plane to actually cut into to be able to sew a second valve in. And remember, because we're doing this surgically, you don't injure the LVOT or mitral valve or the ascending aorta. Now, with TAVR explant, it depends on how stuck the valve is, and the longer it's in the body, the harder it's going to be the explant because of the scar tissue that's held in. Especially when it's stuck to the LVOT on the aorta, you now have to define the plane to careful, meticulously. It's like trying to dig out a fossil from the sandstone. You have to really meticulous, because if you injure that, you now have to have more extensive surgery. And with the self-expanding tall valve, you can imagine it can be stuck in the ascending aorta. So now you have to open the aorta higher. You might have to have a different cannulation or cross-clamping strategy. So it's not just a straightforward AVR or straightforward open heart surgery anymore. And finally, if you implant the first valve deep, you might injure the mitral valve on the manual septum. So you now create a VSD. You might have to replace the mitral valve. It's a much more complex operation. So these are what some of the explanted TAVR valves look like when they're implanted a long time. You can see it's actually quite impregnated with the frame against the native anatomy. And you can see some of the potential cardiac structures that can be at risk of injury when you remove these valves. Now, how the outcomes, you can see certainly the mortality is very high. The observed to expected ratio in terms of outcomes are worse than index TAVR. Most of the time it's due to PVL and SVD and, of course, endocarditis. We're part of this explant registry. As you can see that here, the mortality and stroke rate at 1 year is extremely high. You can see that's almost 30% mortality and 18% stroke rate. Of course, these are early experience, and we're now getting better at doing this, but certainly it's still quite challenging, and case is quite different. You can see that here, if you look at isolated versus concomitant, you can see almost half of the patients require actually additional cardiac surgery. So it's not just isolated AVR. And you can see if you need additional surgery, well, of course, your mortality and stroke rate is going to be higher. You can see that here very clearly. So certainly it's not something to trivialize. Now, what about balloon versus self-expanding valve in terms of being explanted? Well, fortunately, there's really no difference between the two in terms of mortality outcomes. And you can see that here. And what about if you compare explant versus redo TAVR? So this is a registry we put together. And you can see that actually, of course, explant will have a higher early mortality. But if you make it through the first year, you actually have no more survival difference compared to redo TAVR. Having said that, the TAVR explant patients do come back earlier because of this paper actually excludes patients in endocarditis. So it's not because of endocarditis. It's mostly because of PVL and other issues. And you can see that if you have severe PPM, you're more likely to need TAVR explant. Now, what about if you can't explant a valve? You don't want to kill the patient, obviously. So you would need to be meticulous, but at the same time, one easy option is to just take out the leaflets, because that's really what offends the coronary obstruction, and you can actually implant directly a second valve afterwards in the operating room under fluoroscopic guidance. Now, we talk about actually the techniques are evolving for TAVR explant. As you can see here, the root replacement now actually is quite rare. We now have a roll technique to actually compress the balloon expander valve and peel it off. Self-expanding valve, we can actually compress the outflow, almost like re-crimping the tall expanding valve away from the aorta so that we can remove it safely without injuring it. Of course, endocarditis is still an issue. Mitral valve surgery after previous TAVR is actually quite challenging because, for example, we have a low-risk patient with aortic valve and mitral valve disease, and patient obviously can get a TAVR because he's low surgical risk. But if the patient has primary MR or patient needs surgery for the mitral valve, technically you cannot do TEER on a low-risk patient. So you may need to still operate on this patient with pre-existing TAVR, and that could be a challenge in terms of surgical exposure. We do believe the mortality will improve, and there might be a onus to have surgeons referred to centers of excellence. So this is just a summary of TAVR explant. This is a paper that we're going to come on in JTCBS focusing on techniques. and we'll have one hopefully later in Jack in terms of more for the cardiology audience. And you can see some of the basic techniques we can now use that can be standardized to actually remove these valves safely, and we can reduce the mortality risk. So in summary, I think redo TAVR is a top issue in lifetime management after TAVR, as you've seen in this presentation. Redo TAVR volume will grow in the next 10 years. We've seen it in our center, and multiple factors, as you've seen earlier, make the workup more complex than TAV and SAV. New vocabularies and concepts need to be understood, as you saw earlier, to evaluate redo TAV feasibility and also procedural planning. The app will be instrumental, I think, in helping heart teams to evaluate these patients and picking the appropriate second device. TAVR explant, as you saw, unfortunately remains a high-risk operation. We are optimistic as a surgical community to improve this and make it a better operation for our patients. But I think what heart team needs to take into consideration when patients come for the first aortic valve intervention, whether it's surgery or TAVR, you need to figure out what the lifetime management strategy will be in both coronary disease and bioprosthetic valve dysfunction, so you give the best option for the patient. Now, this is a workshop that we did last year. Edwin and Zim were also part of this in terms of looking at a lot of different hot topics on this subject area, and we now starting to come up with consensus documents, hopefully to help guide and advance the field forward. And on that note, I thank you very much again for your invitation and attention, and happy to answer any questions and discussions.
Gilbert, thank you so much. That was really a phenomenal presentation, one of the best I've heard on Redo TAVR. And I really liked it because you really, went through all the challenges and the different approaches. Because I think you're right. This is going to become a major issue for those of us, who are in the structural world and do transcatheter valves. Is how do we deal with the failure of these valves? And I think, as we go further and further, I mean, we just learn more. You mentioned, when we did our first paper years ago, even just projecting this, we knew so little. I mean, we were still talking about wrist planes and trying to figure out what the distance is. And now seeing how detailed your workup is of a patient for TAVR and TAVR, it really is like, it really reminds me of how much we've learned in this time and how much we still have to learn. So really thank you, because I think you're really leading this field, and we all are very appreciative and are learning a lot from you. I obviously have questions, but before I start, let's maybe pass it on to Edwin and to the fellows, and just see if there are any questions from our from the attendees as well.
Yeah, great. I agree. Thanks, Gilbert. That was really, really great. Phenomenal review, very educational for me, and I'm sure the entire audience. I guess I have a quick question, just related to, obviously, there's a lot of subtle complexity, underappreciated complexity in terms of redo TAVR. And then when we start thinking about doing more and more low-risk patients, how do we really optimize that first device to make sure it's not going to fail earlier than we would ideally want it to? There's lots of discussion, as you know, at the Heart Valve Collaboratory about working so hard over the years to make it very minimalistic. Is that now maybe a time to shift back the other way for younger, lower risk patients? Are you doing more TE in your lab? Like, what are your strategies in that situation?
Yeah, no, great question, Edwin. Great point. I think, one of the interesting aspects over 20 years of TAVR now, right? Since, and unfortunately, I mean, I'd like to mention, Professor Longcrepied recently passed, and we'd like to extend our gratitude to him for leading this field and benefiting over millions of patients around the world. But on your question, I think we've been taught to, basically performing TAVR back in the 2010s when it first started. You just put the valve in and you leave and you go on to do other things, because that's what it's designed to do.
Well, at that stage, we were just happy to get the patient off the table alive.
Correct. Exactly.
Right.
So and then of course the whole trend of minimalist in terms of transthoracic echo, constant sedation. So really, and you know this as an imager, Edwin, that a lot of times some sites don't even do a transthoracic echo. They put the valve in, and actually I got a funny, not so funny rather, the little floral image of a patient who had a TAVR from a site in the United States, and they said, "Oh, there's no PVL." Well, guess what? The valve's in the aorta. There's no PVL, obviously, when the valve is not even in the native anatomy. But all kidding aside, I think we need to really think about low-risk patients, not just younger patients. What valve you pick for the first round in terms of sequencing, based on the CT anatomy, what will give perhaps the best hemodynamics or perhaps coronary access. And finally, we are no longer just talking about PVL in terms of post-dilatation or pre-dilatation or crossing the valve. We talk about how do you expand the first valve optimally to, situate in its native anatomy. I think that we've done that now routinely. So, for example, with balloon expandable valve, especially Resilia, I think, I see you do this quite often as well. I think you've been pioneering this, that we call it double tap technique, where you can see clearly, even without adding volume to post-dilate, you actually expand the frame a little bit more fluoroscopically. And we do post-CTs now quite often in some of these patients, especially bicuspid, especially we are concerned. And you see that the frame itself remains underexpanded. So I'm concerned that these valves may not last as long as we would have expected. And we're now seeing that coming back. And almost all of them, I have not seen exception that they are underexpanded, whatever types of valves they might be. So I think there's now maybe an impetus of shift for us on the podium to impart for most operators out there that is optimizing the index TAVR to confer durability. I think this is under this mentioned, and I think needs to be emphasized more.
No, I couldn't agree with you more. I mean, Edwin mentions this because, this morning we have a TAVR to do in a young low risk patient with bicuspid. And as a group, we've decided now to almost go backwards, right? Because we've been doing everything so minimalistic. We pace over the wire. Our TAVR procedures are 30 minutes now, but we realize that there's, you can take that too far, unfortunately. And so when we look at our data and we look at patients who come back, one of the group of patients where I've been unhappy about is the bicuspids. Because, if you're going to do a bicuspid, which is, I think, surgery is agnostic when it comes to bicuspid, but when we do TAVR, we take a big responsibility. And it's the group of patients, I think, where our outcomes are not as good as they are with tricuspid. There's no randomized data, right? It's all single arm registries. So we've actually decided as a group to go backwards in a sense that when we do young bicuspids, we're now going to do it TEE guided. So we can really be sure we get good expansion. We're not risking damaging the annulus, and there's no PVL. Because we've also, after so many years of TAVR, I was thinking, I've done thousands and thousands of TAVR, and in the last year or two, I see things I've never seen before, right? I'm seeing now patients who come back with PVLs and hemolysis on a TAVR valve, which I'd never seen before, right? I guess, and is it because we're doing more or we're just looking for these things
No,
better?
Sim, you're very good point. We've seen some cases that we actually, well interrogated trivial PVL and now come back as moderate. I don't know if it's because the frame, recoil because the calcific burden. But yeah, no, I agree with you. And especially, I think the audience should be aware that there are new TE probes coming that are much smaller than current existing probes. And Edwin has been, playing with some of those. And you can do constant sedation. Doesn't mean that you have TE and need general anesthesia, right? So I think that we have to be very, thoughtful about what we say. That just because people associate TE, you automatically need to put a breathing tube in. Absolutely not true. Absolutely not true. And I think with the newer probes coming, you can get better, resolution and picture quality without compromising the flow of the procedure.
Absolutely. Let's pass it on to some of our fellows. Andre, you have your hand up.
Yes, hi Gilbert. First of all, congratulations for this amazing lecture. It's really a state of the art on what is known on TAV in TAV. My question is, when we do redo TAVR, in a degenerated TAVR is completely different from a surgical valve, and particularly because a surgical valve has the dimension we know of the valve, a transcatheter valve can be under or over expanded. As you showed before, a 26 sapien can go from a 23 to even a 27 valve. So since you are involved in the redo TAV app design, how are you accounting for this? Because we don't know how much a degenerated transcatheter valve can expand, if the valves are different in expansion, if the expansion is uniform. What's your take on this?
Yeah, no, those are great questions. And congratulations, by the way, on your recent editorial. I haven't read it yet, but I've seen it on social media. So well done. So, so to your point, that's why we really would prefer, if we can, to get the pre-index TAVR CT. That tells you a lot about the root anatomy what the calcified burden is, to Azim's point, whether it was a bicuspid versus tricuspid, because you can't tell, after the valve goes in, because it's all scrunched up. And then from that, you can determine, can you safely expand the first valve to accommodate the second valve? Here's the reason why I say that. If you look at balloon expander, which is short valve, most commonly used, right? If you are constrained already, we know that, and the Vancouver group has done benchtop study. You put a second valve and it's been published, you can't really expand two valves together in terms of overall anymore. So if you put a second valve is constrained and your first valve is always constrained, you have a problem now. How are you going to think about the durability of the second valve when you can't really expand beyond what it's supposed to be? So I think your best shot, if you can do it safely, is to try to optimize the landing zone, what I call it, of your first valve, whether it's a tall valve or a short valve. And even tall valve can be underexpanded too. And I think one thing you would need to be mindful, as you rightfully mentioned, and CT unfortunately cannot predict this, maybe some simulation models can, is how much the valve expansion of the tall valves may lead to coronary obstruction. And that's a very good point and very valid point. We just don't know how much to expand. And so obviously, if you're concerned, then I would say that you should be err the side of caution and protect the coronary if you need to.
Absolutely. I mean, I have a question related to that, but I'm going to finish with the fellows first. Antonella or Chris, do you have any questions?
Hi, Chris Jenkins. Great talk, by the way. I was really phenomenal. Just a really quick question. For patients that have maybe had a redo, and they develop an issue with the redo valve, such as, like, for example, endocarditis or anything. Let's say this patient is potentially a surgical candidate. What options do these patients have in that sense?
So great question. So I'm going to break your question down to two situations. So I think one situation is TAVR inside. So the patient has a surgical valve, you do a TAVR inside, so TAVR inside a surgical valve. Now patient has endocarditis or reason needs to actually remove both valves. Actually, that's rather safe. And actually, the Michigan group has actually published this data looking at the STS database versus if you have to do TAVR explant. The reason is that the TAVR valve is inside a surgical valve, right? So it's constrained. So you can just pop it out. There's no injuring to the cardiac structures nearby. And then you can just take out a surgical valve and put a new one in. With two TAVR valves, it's a little tricky now, right? So because let's say you have a tall valve inside a short one, okay? So tall valve being the evolute valve, for example, it's going to touch the aorta potentially. Now, if it's a longer implant, you're going to have to figure that out first, and you have to crunch that up. So that comes out. Now you have to take out the short valve, the balloon expander valve inside.
Yeah.
Right. So you have to do two things. Now, popping the second one inside the first one should be easy because it's not going to be stuck that much. But if you think about a sapien inside the evolute, taking the sapien out from the inside should be easy because it's inside protected by the cage of the evolute. But taking out the evolute, it's going to be a big, be like a beast basically to have to deal with that. So yeah. So hopefully it hasn't had a lot of those, but when we do more redo TAVR, we know that patients will say, well, let's get a redo TAVR, and we don't know what the durability is. And if it's only 1 year, you're going to have to buy yourself a surgery, and it's going to be a challenging surgery.
Okay. Thank you.
Thanks, Chris. Antonella?
Yeah, good morning, Dr. Tang. Thank you very much for the presentation. I'm a big fan. So if I understood correctly, the main concern is the coronary reaccess, right? Do we have already data about the rate of success of coronary access after TAVR in TAVR?
Yeah, so as you know, they're mostly done on bench model because that's easy. You can line up however the valve you want and implant whatever depth you want. And you saw earlier, there's still very few cases of TAVR in the United States. Although, I heard anecdotally, last year has definitely, increased significantly. I'm sure this year as well. But, thankfully, I think most of us, at least in our workflow, we do a cath first to see if there's any native CAD before we actually put a second valve in. Because we know that the leaflets will be pinned, and so there could be consequences if they have moderate obstructive CAD, and engaging that, as you saw in my presentation, with the cells not being perfectly overlaid, it's going to be a very, very problematic. So thankfully, not a lot of these cases have to be done clinically after TAVR or redo TAVR, but certainly it's conceivable that it will come later on, just like what we're talking about coronary access after first TAVR now.
Yeah, that is why. Thank
Yeah.
you.
I like Antonella's comment, Gil, but it's maybe those of us who are working in this field and we're doing all these registries together. It's something maybe we need to be thinking about as we do our TAV in TAVR cases and just seeing if we can access the coronaries after the second valve. I think it'll be interesting, novel information for the community. So thanks for the suggestion, Antonella. Remind
Very
us
well.
whenever we do a TAV in TAVR now, we'll try and
Sure.
access at the end to see how difficult it is.
Yeah.
There's also a
Also,
great
there's a
question.
question from the Q&A, Azim.
Yeah. So this is Safwan, one of our imaging fellows, who does a lot of our CTs, and we have a great imaging group who are very motivated. So firstly, he said, fantastic talk. Thank you for giving us this talk and also for sharing your knowledge on YouTube. A lot of our fellows watch your videos, Gilbert. They're really well done. And his question is, how do you take into consideration LVOT and aortic root eccentric calcification in the setting of redo TAVR?
Yeah, great question. Now, actually, answer your question in 2 points. One is redo TAVR and one is TAVR explant. So with redo TAVR, I think that's where we need to look at the pre-index TAVR CT, right? Because once you put the TAVR in, you don't know whether it's LVOT or annulus because you don't know if the valve was implanted deep or shallow. So you have no reference point to see where that calcium is other than it's like, let's say, extended all the way down to MAC, right, in the mitral valve. So that's why I think it's very important to see whether there is a calcification in the pre-index TAVR CT at the annulus and LVOT. And you can actually try to match with echo on the mechanism of failure. So for example, if the valve is underexpanded, there's paravalvular leak, is it because at that location that's causing the valve to fail? And so the information that you get is going to be able to guide you whether is it safe to expand this valve further before putting a second valve in. Maybe it's not. Or if it's PVL, can you safely post-dilate this to reduce it? Because if not, you might have to plug it, or maybe you need to go to surgery. So it's actually very instructive. To your second point about that I want to mention about TAVR explant is that these calciums are notoriously difficult even for surgeons to remove. That we need to basically use a rongeur to kind of yank it out and break it into pieces. So that's why that when you do TAVR explant, once you remove this, we have to make sure that you have to clean that up, and often it's not that straightforward. And so even for surgical valve implantation, it can be challenging.
Yeah, that's something I've never thought about, right? And I'd love to hear more about this, Gilbert. Even, often we see these patients, especially bicuspids with very calcified valves and calcium in the alveoli, and that may often be a reason that I go, oh, this is not a good TAVR candidate, let's send this patient for surgery. Now, I can understand the leaflets you can probably cut out, but what do surgeons do about these big chunks of alveoli calcium? Does it result in more PVL afterwards, or a higher risk of injury to the membranous septum or high pacemaker rates?
Yeah, no, those are great points, Azim. So yes, you're right. So so you need to use what we call rongeur to kind of like, taking out bones, you have to put in pieces, you break it up, and you have to make sure you suction because you don't want these to embolize to the brain, right? They're raw calcium. So that's very important to actually remove it. You want a clean and smooth plane. So to your point, some of the paravalvular leak from surgical valve is because they probably did not debride it properly, and so there's a gap there, or maybe they did not tie the suture down properly to occlude that. And you're right. So if the calcium is sitting right near the membrane septum, there is a higher risk of injury to that and causing heart block. That's absolutely right, because we can't just leave the calcium there because you can't put the sutures and the needles through the calcium. So you need a soft spot to be able to put the sutures through and the needle through. So that's why we have to debride those.
Right.
And if you debride too aggressively, to your point, you can make a hole, and that could be a big problem.
Yeah. So, do you have any other questions? I had one last question, right? So when we think about redo TAVR, I mean, the things we worry about, the challenges are the coronaries, whether it's coronary obstruction or coronary access. It's the hemodynamics because, we have this Russian doll effect, and it's the durability. Those are like the three things we're thinking about when I do the case, right? The durability, I'm going to, often may not matter to me because often when I'm doing these redo TAVRs, they patients who are pretty old, and they're very symptomatic. They had their TAVR when they were 80, and they're now, in their late 80s or 90s. So maybe durability in that group of patients is not so important. The biggest issue is really coronaries. That's the thing that worries me the most, because no one wants a patient who dies on the table because you occlude the coronaries, right? And right now, our approaches are limited. We can do basilica, maybe, if the first valve was well aligned, it would work, but often it's not well aligned. Or we could do coronary obstruction, or we could protect the coronaries and maybe do chimney stenting, neither of which are ideal. The one thing I was just thinking as you were talking and showing all those different pictures, what do you think about for TAVR in TAVR, like novel valves, things like the J valve or the Yenna valve, that actually hold onto the leaflets instead of pushing them out, so that you give the patient a new valve without creating a covered stent?
Yeah, I think that's an interesting point. I think the question, though, is that with these kind of Yenna valve that clasp the leaflets that protects against the root, when you put a second valve in, how much are you to expand, right? In terms of within these Yenna valve or J valve to be able when the Yenna J valve fails. So,
No, but
so
I'm actually saying using a Yenna or J valve to treat a
oh,
failed sapien
so that's a
or
great
to
point.
heal a failed core valve.
Right, there's fail core valve, but then you sit very high because remember you have to engage the leaflet.
Engage, yeah.
So unless you really push it down to see whether you can safely deploy that way, you might end up setting the second valve higher, and your risk of coronary access is going to be more challenging potentially.
Yeah.
But you have a very good point. Maybe some of these newer generation that alignment valves may be beneficial to some of these situations. I think the question is again whether you might have to pick a smaller size valve and trade off hemodynamics. That we don't know.
Yeah. So basically, the bottom line is we need better valves that are going to last forever.
Yeah.
Or we need modular valves, right? Which has
Right.
always been my dream, where you put the valve in and then you somehow can remove the leaflets and put a brand new valve in.
Yeah,
That would solve our
there was a company back then. I'm sure you might remember. It was in London Valve. They had this surgical valve. You dock it and you remove the leaflet. You put another one. I mean, it didn't go anywhere because here's the reason why. I think people underestimate that there's healing process there. It's not like fresh that you can just remove it. It's things are healed over, so there's no way to actually engage that to unclick it. Even for example, people talk about the Inspiris valve, right? The surgical valve, they say, oh, it's TAVR friendly because you can stretch the frame. The reality, once the thing heals in, it's not that easy. It's not like you can just put a balloon, expand a valve, and then just stretch it. It'll be like come straight cylinder. It doesn't work that way. So.
Yeah. Gilbert, once again, thank you so much for your time. I know you have a busy day too. We've all learned so much from you. You really are leading this area, and it's always been fun for us to work with you and collaborate with you. Thank you for your teaching and your friendship.
Thanks very much, and have a good rest of the day, and we'll see you again in person soon. Thank you for the invitation.
Take care.
Bye.
Bye now.
Bye.